By definition, continuous murmur is one which starts in systole and continues through the second heart sound into diastole. It need not be present throughout the cardiac cycle. Classical continuous murmur is the murmur of patent ductus arteriosus with left-right shunt. It is best heard in the upper left sternal edge and is known as Gibson's murmur in Gibson's area. When pulmonary hypertension develops, the diastolic component is lost and sometimes it is called atypical PDA with only a systolic murmur. Severe pulmonary hypertension can manifest with a diastolic murmur of pulmonary regurgitation. Differential cyanosis with cyanosis confined to lower extremities is a hallmark of PDA flow reversal. Coronary arteriovenous fistulas can also cause continuous murmurs, though not as loud as the murmur of PDA. A variant is coronary cameral fistula draining into the cardiac chambers. We had reported a case in which a fistula involving 3 major coronary arteries drained to the left ventricle and presented with an apical diastolic murmur mimicking that of mitral stenosis. Interestingly, the person was asymptomatic. Rupture of aortic sinus of Valsalva into right-sided cardiac chambers is another cause of continuous murmur. The classical form of RSOV into RV has a murmur with diastolic augmentation. This contrasts with the peaking of PDA murmur around the second heart sound. Diastolic augmentation of RSOV to RV murmur is because the tract from aorta, usually passing through the right ventricular outflow tract, gets compressed by muscle contraction in systole. If the RSOV is into the left ventricle, it can present with diastolic murmur, but that is quite rare. Cervical venous hum, a common finding in children, especially in those with anemia, can be confused with the PDA murmur. It is heard well over the neck and upper thorax and changes with position of neck and body. May be heard only in sitting position and disappears with compression of the lower part of neck as it is due to flow in the jugular veins. Aorta pulmonary window is another rare cause of continuous murmur, but most often continuous murmur may not be heard because of early development of pulmonary hypertension. We had the opportunity of hearing one in a young adult with a small defect long back, which was considered to be a rare occurrence. The defect with continuous flow was documented by color Doppler echocardiogram done elsewhere at a time when it was not available at our institution. Anomalous origin of left coronary artery from pulmonary artery, Al-Kappa, is another potential cause of continuous murmur. As the pressure in pulmonary artery is low, continuous reverse flow occurs into the pulmonary artery as a result of collaterals from other coronary arteries. In fact, that acts as a small left to right shunt. Though stenosis of proximal coronary arteries also may manifest with continuous murmur rarely, the classical description is a diastolic murmur. Initial documentation by Dock et al. Was an early diastolic murmur. That high-pitched murmur was thought to be from a stenotic left anterior descending coronary artery, which was suspected to have a recanalized thrombus. Mammary souffle of pregnancy due to increased flow in local vessels, pulmonary artery branch stenosis, bronchial collaterals, and intercostal arteriovenous fistula are other causes of continuous murmur over the chest. A restrictive atrial septal defect in the presence of mitral stenosis is another cause described for continuous murmur. The high velocity flow compared to a non-restrictive ASD occurs due to high left atrial pressure in mitral stenosis. In those with large ASD and mitral stenosis, even the mitral diastolic murmur is of less intensity due to rapid decompression of left atrium. But pulmonary systolic murmur becomes louder due to the torrential flow.